Dear colleagues, today I will present a case of congenital diaphragmatic hernia diagnosed during a second trimester screening exam. This is a rare anomaly in the development of the diaphragm, resulting in herniation of the abdominal organs into the chest. It can be isolated or associated with other malformations and may be due to genetic or chromosomal causes. In 85% of cases, the hernia affects the left hemithorax with possible herniation of the intestines, spleen, stomach, and rarely the left lobe of the liver. The most common type of diaphragmatic hernia is the Bok-Darlic hernia, which occurs in the posterolateral area of the diaphragm. The examination is performed at 19 weeks. 6 days later, the presence of the stomach inside the chest is immediately evident, with a resulting mediastinal shift, meaning the heart is displaced to the right. Upon closer examination, it is possible to see that in this case, not only the stomach but also part of the small intestine are present in the left hemithorax, as is typical in left-sided diaphragmatic hernia. In the clip that I am showing you now, you can clearly see a right parasagittal scan, where the left section appears to be completely normal and the heart is resting on the right hemithorax, where it is clearly visible. The frequent association of diaphragmatic hernia with cardiac malformations, especially interventricular and interatrial defects, requires a careful study of the heart with fetal echocardiography, which in this case is normal. The only cardiac anomaly found is in fact a positional anomaly with dextrocardia, which is secondary to mediastinal shift, and a very slight rotation of the axis that appears between mesocardia and levocardia. The study of the remaining fetal anatomy is also completely normal, allowing us to reasonably exclude the presence of associated malformation. The biometric measurements correspond to the gestational age, and the amniotic fluid is also within normal limits. The main consequence of diaphragmatic hernia is pulmonary hypoplasia. The herniated viscera, in fact, act as true space-occupying lesions, compromising the development of the lungs and heart. A prognostic marker in this regard is the calculation of the lung-to-head ratio, in which the area of the lung contralateral to the hernia is measured and compared to the fetal head, allowing this parameter to be assessed at different gestational ages. The area of the contralateral lung can be calculated either by tracing its perimeter or by measuring the area along its two longest axes. In our case, the contralateral lung is the right one, and the area is calculated by tracing its perimeter. Next, the ratio with the cranial circumference and the lung-to-head ratio, the so-called head ratio, is determined. In this case, it turns out to be 1.0. The expected ratio at this gestational age is 1.84. The ratio between the observed and the expected values is calculated, and the result is 54%. This data, as you can see in the table I am showing you, corresponds to a mild form of left diaphragmatic hernia, since the cutoff is 40%, which has a survival rate between 50 and 100%. As for the management of the case, after performing a reference ultrasound and fetal echocardiography, it is necessary to advise the couple to undergo genetic counseling and invasive testing with karyotype and array CGH, as well as multidisciplinary counseling involving a neonatologist, pediatric surgeon, and geneticist. In cases of severe isolated forms, intrauterine fetal surgery techniques using the FETO technique should be considered. Ultrasound follow-up should be performed every 3 to 4 weeks to assess fetal well-being and to periodically reevaluate the lung-to-head ratio. Finally, delivery should be planned in a tertiary care center. Thank you for your attention.